we are capturing the biology of cancer at a precision that we weren't able to before. And that has really led to a completely new form of understanding of cancer in general, and lung cancer in particular.
This is the James Cancer-Free World podcast. I'm Steve Wartenberg, and my guest is Dr. Triparna Sen. Triparna is a James scientist who specializes in translational research in the field of immuno-oncology to help better understand and treat lung cancer. Triparna will fill us in on some of the new developments in treating lung cancer and the great research she is doing in her lab. Welcome to the podcast.
Thank you so much. I'm really honored to be here.
Yeah, you're new, which we'll talk about later. So it's congratulations and welcome to the James and the podcast.
Brand new.
Yeah, exciting at times for you. But let's start off with a quick overview on why it's so important to understand and come up with new treatments for lung cancer.
Absolutely. So lung cancer is the leading cause of cancer-related mortality among men and women. It's actually a devastating disease. We have made great progress, but there is a long way to go for us. So lung cancer can be divided primarily into two types, non-small cell and small cell lung cancer. And my lab works on both.
Oh, I hear that all the time. And I know it's complicated, but what is the difference between those two types of lung cancer?
Sure. It's in the name. So non-small cell is not small. So when you look under the microscope, these cells look large and elongated. And small cell lung cancer, which is about 15% of lung cancer diagnosis, so it's not the major subtype, it's 15%. It's these cells, if you look under the microscope, these are small blue cells. So that's why they're called small cell.
They're all small, but when you magnify them thousands and thousands of times, you see a big difference.
Correct. And small cell is one of the most aggressive forms of not just lung cancer, but any cancer. And my lab we have invested a lot of time and resources in studying this disease, which is small cell lung cancer. And I think it is extremely important to study lung cancer, study the biology, and find novel therapies, because first, it is the leading cause of mortality, but also there's a lot of myths associated with lung cancer, and I'll tell you in a bit. So historically, lung cancer has been associated with smoking history, right? But recently, we are understanding that there is a significant population of patients who are never smoker, non-smoker, younger women who are having lung cancer. So it's extremely important to understand this population of never smoker, non-smoker, younger population who get lung cancer. And I think that's very important.
So the myth is not that smoking causes lung cancer. That's true. The myth is that if I don't smoke, I won't get lung cancer. That's the myth, because you're finding non-smokers are getting lung cancer.
Absolutely. So smoking is still the highest risk. Right. It is the highest risk predisposition. But the fact is, anyone with lung can have lung cancer. So it's extremely important to understand that, because that will expedite understanding the biology, understanding drug discovery, also the importance of screening, importance of guidelines, everything. So I think that opens a new door for us of understanding lung cancer in this younger population and environmental risks that we might be exposed to other than smoking.
So understanding the biology of lung cancer and the cancer cells that cause it, that's fascinating. And how do you do that? I'm picturing super powerful microscopes, but I know that's just the start.
Yeah. Well, biology is really our North Star. Research is our North Star.
Yes.
I think the amount of investment we have made in research has really made us where we are today in terms of treatment. And here at the James, I think there is a very rich body of researchers who have invested their time, not just in lung, in any form of cancer. And, when we think about research, it is a multifactorial, multidisciplinary thing. So it's not just microscope. Microscope is one part, which lets us see the cells, but it's also studying, molecular biology, which we do a lot of, drug screening. We do a lot of sequencing. So looking at the DNA and the RNA, looking at the protein. We do a lot of RNA sequencing. I told you we do a lot of single cell sequencing. We do a lot of CRISPR screens, so a lot of molecular biology, cell biology. You should come to my lab because there are a lot of cool gadgets there.
So it's really understanding the millions of parts and things that are in a cell.
Yeah, and we're still not there. I mean, the more we understand, the more we understand how much we don't know. So more we know, more we understand how much we don't know. But it's fascinating when you look at the biology, is how complex and the disease is, and how much it is heterogeneous in nature. And that's what we are understanding now with these newer technologies like single cell sequencing. Earlier, we were not able to capture cancer in the resolution that we can do now with these high resolution microscopes or single cell RNA or ATAC or other technologies. But we are capturing the biology of cancer at a precision that we weren't able to before. And that has really led to a completely new form of understanding of cancer in general, and lung cancer in particular.
Oh, good. That perfectly segues into my next question, which is, what has it led to in terms of, now you did say we still have a long way to go in terms of treating lung cancer, but what currently are sort of the main ways to treat lung cancer?
Absolutely. So, there are 2 or 3 main areas which we currently focus on in the lab. Is that we want to understand the biology of the cancer in 2 ways. Is how does a cancer evolve, right? How does a cancer initiate? How does it go from a normal cell to being this malignant cancer cell? How does a cancer even start? So to understand that, so that we can stop cancer maybe at its initiation. And then how does it go from probably this benign state to this malignant state, or maybe this localized disease to a malignant disease, where it spreads from its primary area to this metastatic area, which is where cancer becomes truly aggressive. It goes from my area of research, it goes from the lung to the brain or lung to the liver, which becomes really problematic when you have this metastatic disease. So we study that. How does a cancer spread? And then why does a current therapies like chemotherapy, immunotherapy, targeted therapy, why do they stop working? And when they stop working, what can we do about that? Like what are the combinatorial regimens that we can give them? And right patient, right treatment. That is very important, because these aggressive disease, the window of opportunity for treating them is usually very less. So how can we select patients for the best drugs, which we call predictive biomarkers?
So how do you do that? I take it it's analyzing that specific patient's cancer cells, and that helps you match them to the right drug?
Yes. So we do this in different ways. The best way to do that is to learn from the patient, right? So we partner with the clinicians. We learn from clinical trials, and we see which patient responded to which drug. And then hopefully collect tissues and blood from these clinical trials, or from routine collection in our centers, and then take it back to the lab and then analyze with the platforms that I just mentioned, the RNA sequencing, DNA sequencing, and proteomic analysis, and then see who are these patients who actually responded to the drug. And is there a difference between the patient who did not respond to the drug? And hopefully identify some biomarkers or some determinants that tell us, okay, these are the patients that had a high expression of these certain genes or these certain proteins that made them resistant to begin with to these drugs. And then we can then make these selections. I'll give you an example. So in non-small cell lung cancer, these are these oncogenes like EGFR, KRAS, that really determine the the metastatic proclivity of this disease, the biological complexity of this disease, and also what drugs they should be treated with. And that has led us to unprecedented advancement in non-small cell lung cancer. So these patients now come, they get molecular testing. If they are EGFR mutant or KRAS mutant, they have targeted therapy for that.
So that the EGFR and the TRF, these are
Genes.
Genes or proteins on the cancer. There's something on the cancer cell that the immuno-oncology can see and attack.
Correct. So when these patients come into the clinic, they get tested. So their tissue is collected and we do gene testing. So it's an NGS or whole exome sequencing. And with the DNA, we can identify mutations, right? So we see there's an EGFR mutation or there's a KRAS mutation. And then there are drugs that are now approved
for
that particular gene mutation. So for example, there are drugs approved for EGFR mutation, and this patient now goes on to that therapy. There are drugs approved for KRAS mutation, and that patient now gets that therapy. So now it has become very precise, like we call precision medicine. And that's what it means, is it becomes precise. We are not doing one size fits all approach. We have this method of where we are selecting the patient for the best treatment for them. And that has really led to the improvement of their survival, of how, we are seeing now long-term responses for these patients, which we were not able to see even a decade ago. I think it is amazing where we are now from where we were a decade ago.
Wow. So if I understand correctly, so you, meaning the scientific community of cancer experts such as yourself, have identified these two targets, FGFR.
There are multiple, actually.
And they're working much better, but sometimes they don't work. And so you're exploring why they don't work so we can make it better. And you're also looking for new targets that you can then develop new drugs to attack for new targeted therapies that will be even better.
Correct. So, for the drugs that we currently have, it's fine. But sometimes, a lot of the times, the problem is the patients don't respond to these treatments, right? They develop resistance. So we really are investing a lot of effort to study how do they develop resistance? And once they do develop resistance or these patients stop working, what can we then treat them with in this relapse test setting, on this resistance setting? And also, of course, all the times we are looking for novel drugs that could be working better. And as I mentioned, small cell lung cancer, this has been a very aggressive disease where, drug development has been stalled for decades, actually. These patients usually used to get just chemotherapy for the longest time. And then we had immunotherapy being introduced back in 2018, which has led to improvement. And now we are seeing new classes of drugs being developed thanks to research, like T-cell engagers, bispecific T-cell engagers, antibody drug conjugates, which are now showing benefits in patients like we have never seen before. So this is a progress.
Okay, that was a great overview, and that leads us into exactly what you're doing in your lab, which is what you just described. But first, we're going to take a quick break, and then we're going to come back and really explore some of these amazing things you're doing in your lab.
The best outcomes for treating cancer come from early detection and early diagnosis.
The James Cancer Diagnostic Center at Ohio State
is designed to provide rapid evaluation and a clear diagnosis.
We are transforming care by giving patients direct access
to cancer experts who study and treat cancer every day.
If you think you have cancer, the choice is clear.
Choose the James Cancer Diagnostic Center.
We're back, and now it's time to dig into the fascinating work you and your team and your lab are doing in so many different areas to identify what's going on in lung cancer cells and how to defeat them. So fill us in.
Yeah, absolutely. I'm very excited to talk about it. So my lab actually focuses mainly on the biology and precision medicine for thoracic malignancies. And what that really means is, and I'll go into specific projects in a minute, but what that really means is we really want to understand the biology of lung cancer so that we can treat it better. And there are several areas that we focus on. We focus on how does a cancer actually initiate, right? How the cell of origin, and how does it initiate? And then once it initiates, how does it evolve from this from a benign tumor to this very highly metastatic tumor? So evolution of tumor. How does it develop resistance? So a cancer can develop resistance through multiple mechanisms. And we study this unique mechanism called histological transformation. It's actually a fascinating mechanism when a cancer actually completely changes its histology. So a non-small
What is histology?
A non-small cell lung cancer, when it's treated with a drug like a tyrosine kinase inhibitor, let's say an EGFR mutant lung adenocarcinoma is being treated with a tyrosine kinase inhibitor, one of the mechanisms by which it gets resistant to that is by transforming to a new kind of lung cancer, like small cell lung cancer. So the histology or the subtype of cancer shifts. So now the drug can no longer recognize the tumor anymore because it's now a different type of tumor.
A cell can change its biology
completely. Yeah.
One cell, or it takes generations of new cells to do that?
That's a great question. We have seen this process emerge anywhere between 6 months to a couple of years. So it takes a few generations of cells to do that. And it's a very complex and dynamic mechanism, right? So we don't fully understand that. And that's what we are doing, is to understand how does this evolution, as you call it, emerge, and how many rounds of cell division does it take, and what are the predictors, and how can we treat these cases? So this is one of the areas that we study. We also study how can we make immunotherapy better, because immunotherapy has really changed survival in patients with lung cancer, and immunotherapy is currently in every stage, limited stage and extensive stage for small cell lung cancer. But unfortunately, only a minority of patients see durable benefit from immunotherapy. So our goal is to see how do we have more benefit, durable benefit, for the majority of patients with small cell lung cancer. So we are thinking about combinatorial strategies.
Combinations of different drugs.
Correct, with immunotherapy. And we are looking into targets like DNA damage response inhibitors, epigenetic modifiers that could be combined with immunotherapy to make the response of immunotherapy better. So these are strategies that we are identifying, and also novel drugs, right? There are several drugs that I mentioned, like surface targets. So these are bispecific T-cell engagers or antibody drug conjugates that are currently, really showing benefits in patients. So we study how do they work, what are the resistance mechanisms to these drugs, and then finally biomarkers is how do we select the best patient for the best drug. And these are all the things. I have quite a big group, so these are all the things that we study. We partner quite a bit with the clinicians so that we can learn from the clinic and bring it back to the lab, and at the same time, how can the clinic learn from the lab? We do very bench to bedside research, translational research, and I think that's really matters, where the both side learns from each other.
Wow. So if I'm understanding correctly, some people, immunotherapy is working in some people, and some people may have a long-term remission, but other people do not. And you're trying to figure out the difference in that, so that can help you create combinations or new drugs that will lead to long-term remissions for more patients.
Correct. And, also understand who are these patients who have long-term benefits, right? Because that tells us the ideal biology.
Does it go back to something you said before about how cells change and become resistant?
Absolutely.
So someone getting an immunotherapy for their FGFR, it works for a while, it works, and then the cells change.
Right.
So they're resistant to it.
Yeah. So immunotherapy, EGFR, if they have an EGFR mutation, they will get something called a tyrosine kinase inhibitor, which is a targeted therapy. Immunotherapy is given like immune checkpoint blockade, like PD-L1 anti-CTLA-4 that is given to specific subtypes of lung cancer. It is given to small cell lung cancer as a first-line therapy. It is approved currently, which is given in combination with chemotherapy. But only about 10% patients actually have durable benefits. So we are really trying to understand how can we really have a majority of patients respond to these drugs? And that's where, we are combining them with these new classes of drugs.
Wow. And something else you mentioned, how you work with the clinicians. I've heard a lot of people talk about that here at the James, that there's a very strong collaborative effort between, you're in a lab and you don't really see patients that often. You're just there in the lab, you and your team, hours and hours studying, but that getting to work with the clinicians and exchanging ideas sounds like it's really important and not totally unique to the James, but something that's really a strong culture here.
So I think that collaboration with the clinicians is not just important, but it's actually necessary, because to understand a disease, you really need to understand it from a patient perspective. And that's what we are doing it at James, right? I'm collaborating with my clinical colleagues to then either collect samples through clinical trials or through these routine collection of tissue and blood, and see how these patients actually go through these treatments and develop resistance to these drugs. So I think we can learn a lot. And then what we learn from the lab can then be translated into clinical trials, so that the clinical trials also learn from the research in the lab. So I think it's absolutely a dialogue that needs to happen.
So this whole concept of how cells transform and change themselves and become resistant, I know, is one of the areas you really focus on. So tell us a little more about that.
Yeah, it's really a fascinating area, and one of the very significant mechanisms of resistance that not just lung cancer, it's actually very common phenomena in other cancers like prostate, pancreatic, bladder, kidney. We are seeing a lot of cancers actually developing resistance to current line of therapy through this process of lineage plasticity or histological transformation. What that means is that when these drugs are being given to these patients like lung adenocarcinoma or PDAC or prostate ductal adenocarcinoma, they develop resistance through completely changing their histology or becoming a completely new type of cancer. And why that is difficult is that now these drugs don't recognize this disease anymore. And especially for the lung cancer, this is seen very commonly in EGFR mutant lung adenocarcinoma. These are these patients with no smoking history almost, young women who are having now this difficult, devastating diagnosis. And there are no therapeutic options almost that are there for these patients. So we are really investing a lot of time to understand what are the drivers of this process. Can we monitor them up front? What are the predictors? What are the therapeutic targets that we can treat this with? And I think we can learn a lot from other cancers. And I think there is a convergence from this multiple cancer types that go through the same process. So I think there is a huge possibility here at James of collaboration, not just within the lung team, but also this multidisciplinary collaboration between the prostate cancer team, the lung cancer team, the pancreatic cancer team, the bladder cancer team, where we can all come together and understand this apparently very similar phenomena that this cancer goes through this process of lineage plasticity as a mechanism of resistance. So I'm very looking forward to not just progressing this field within lung, but also collaborating with my colleagues here.
Oh, good. That perfectly leads me into my next question about, and I think you just kind of told us why you decided to come here a month ago from Mount Sinai in New York, but I don't want to put words in your mouth, but why did you decide to come to the James?
Oh, several reasons. Well, James is an amazing place to work, and I'm understanding that. I'm here only for about a month, but I'm already seeing sort of the commitment of the leadership, commitment of the physicians working here, that patient care is really at the forefront, and I respect that, and I really value that. Even as a researcher, for me, my goal has always been, how can my research benefit patients? That has always been a driving force for my research. I do very translational research. And I think that's really the goal of James here. So that really fit my culture when I was interviewing here. That really came through. And that's why I think was one of the main reasons is how much they value patient care and here at James. And the second thing is that the partnership between the lab and the clinic is very seamless here. And that's the kind of research I want to do in the next phase of my career. I really want to partner with my clinical colleagues. I want to learn from them and hopefully teach something from the lab. And then we can have this dialogue where ultimately the patient benefits. The clinical trials become better, precision medicines become better, more precise, and we can improve survival for patients. And lastly, there's a huge commitment from the community, which I think is so important. When the community comes together to improve patient care, I think that's where we see a long-term shift in the needle in the right direction. And I saw that while talking to my colleagues during my interview. So I think those were my driving force, the community, patient care, collaboration. I think those really drove my decision of coming here. And so far, I'm very happy.
Well, I think we're lucky to have you here.
Thank you. Thank you for having me.
And thanks for the great work. And maybe you'll come back and fill us in when you further understand how cells divide in the wrong way and how you can fix that.
Absolutely. Thank you.
Okay. This podcast is brought to you by the Ohio State University Comprehensive Cancer Center, Arthur G. James Cancer Hospital, and Richard A. Solove Research Institute. For more information, check out our website, cancer.osu.edu.